Well, thank you very much for inviting us. Well, we started this fact, of course, Remmers van Veldhuizen should be mentioned also because he was together with other persons in North Holland North, the guy who started the flexible act method. Short introduction, I'm Michiel Bahler. I work as a psychologist and an advisor at GGZ North Holland North, forget it. And I also work as a advisor for the Center for Certification of Act and Fact. I won't discuss that really, but it's a center where we look at the model of fidelity of the different teams, Act and Fact teams, which is necessary for the funding. And I'm an advisor of the European Assertive Outreach Foundation, which will organize a meeting in Oslo in 2015. And we're very pleased with that.
I'm Jeannette Bakker. I'm working as a nurse in one of the 3 fact teams in Alkmaar. I brought a picture. Alkmaar, a little city in the northern province of the Netherlands, and it's famous about this tourist attraction, the cheese carriers. I thought I will look on internet what is cheese carrier in Norwegian. So it's Osteberere. Is that okay? And, well, 3 days a week I'm working in the team, and half of my time I'm a case manager and I'm taking care of the clients, and half of the time I'm the coordinator of the team. And next to working in the team, I'm also a member of our Fact Academy. It's a little organization within the organization GGZ North Holland North, and this is a group of workers who go into the Netherlands and give training to the teams who are starting with FACT. And it's very special because all the members of the FACT Academy are also workers in the team. So we're not very high qualified people, but also workers and training other workers in the country. It's like the train-the-trainer principle. Well, we thought today we will tell you something about the FACT in the Netherlands. We will give you a short introduction of the FACT in the Netherlands, and then we will tell you about their daily work with some kind of case study. It's about Martin. Martin is a client was a client in one of our teams, and he is an example for the clients who are in the teams, because 40 to 50% of our clients are also having substance abuse. After that, we do a little summary, and Michael will tell you something about evidence about FACT. So at first, a short information about the Netherlands and FACT.
Well, thank Torle for his comprehensive study about ACT and also about FACT, so we know a bit about the context. I will first show some history, if I know this. First, Netherlands, small country, 60 million inhabitants. 6% of the persons were last year in the care and mental health for any moment. The expectation is that about 1% of them has a severe mental illness, and 110,000 are in care somewhere in the Netherlands. And the dot you see is the place where we work, up northwest in the Netherlands. All right, so this is our region. If it takes an hour to get from here to there, it takes an hour to get from here to there. So that's about the Netherlands, about the distance. It's not very far for your probably. In our region, we have about 600,000, 650,000 inhabitants. We have 2,500 persons with severe mental illness who are in care and who are in care in the FACT teams. And we have 12 FACT teams. They are spread all over the region. There are 5 FACT teams in this region. This is more urban. 4 in this region, more urban and rural. And this is a very rural place, and there are 3 FACT teams over there. And downstairs is the hospital, and there's still some persons living in apartments on the old ground. Above that, there is a forensic act team, which started because we had a forensic ward which is working for more than our region. And we have a mentalization-based treatment team for persons with a severe personality disorder. This is something we started last year, and it's an experiment if it works. Above this, we have 3 acute units spread over the region, and we have a dual disorder unit, and we have a very small intensive treatment ward, which will be merged together. If we go back to 2000, oops, I really have problems. There it is. The care not only in our region, but in the Netherlands, the care was very fragmented, especially for the severely mentally ill. So we had supported housing, we had some working, we had activity centers. Psychiatrists were not connected to the case management teams, so it was very fragmented. And it was the evidence which was known for the persons with severe mental illness was not available for them. So there was no organization, no evaluation of the care which was happening, and what we saw, there were long admissions, there were a lot of admissions for the persons with severe mental illness, and there was a lot of dropout, and persons with revolving door within the acute wards. And the dropout, we saw a lot of homeless people in the big cities, Amsterdam, Rotterdam, Utrecht, especially around the year 2000. That was a reason to look around, and one of the issues we saw was the ACT teams, which Torlev described earlier. So since 2002, the first ACT team started in the Netherlands, mainly in the big cities, Amsterdam, Rotterdam, Utrecht, The Hague. We were evaluating our system in 2002-2003 together with Remmers, and we said, well, is ACT the option, or should we do something else? It's a bit of a Dutch habit, I think. But if you look at the distances, we thought, well, we could handle our region with 2 ACT teams, and probably that will do. But then we didn't have an answer for all the other persons with severe mental illness who weren't severe enough to be in an ACT team. So that was the reason why we thought of another intervention. We have early intervention psychosis team, there are forensic ACT teams in the Netherlands, and there's now youth ACT teams starting, and forensic fact teams for addiction also. Altogether, there will be about 230 teams now in the Netherlands, focused on the severely mentally ill. What is special is this is really a bottom-up movement. So we don't have a policy, a government who says, well, we want to start with ACT teams. It is a movement which started from bottom up because it was an appealing model. It seems to be an appealing. And 120 of these teams are certified. Short introduction. Oops, that's getting better. Fact, as mentioned, is for all persons with severe mental illness in a certain catchment area. And instead of an ACT team and a step-down team, we brought it together in a fact team. It is a flexible response, which we discuss later. It is working in a catchment area, about 50,000 inhabitants, so it's quite involved in what's happening there. And the focus is on social inclusion, and it should be like an ex-principal, the gatekeeper for admission for the acute ward and discharge from the acute ward. It has 2 modes of operation. Intensive case management for persons who are more or less stable, and a high level we use really ACT when necessary if somebody is getting in a crisis or in a relapse. The teams are multidisciplinary. We added a psychologist, which was originally not in the ACT teams. We added it, but for us it's the same as a usual ACT team. So we have the peer specialist, we have the supported deployment specialist, and all the teams have a substance abuse specialist. And the fact teams work in a catchment area, 50,000 inhabitants. We expect about 200 patients with severe mental illness. Because they're in the neighborhood and working there, there's a close collaboration with the police and the housing companies, with welfare, with other companies, and of course also with the primary care, the GPs, the pharmacies. So a lot of communication with the GPs. And having this close collaboration with housing companies and police, there's an opportunity for case finding. So if there are other persons who we don't know who should be in the mental health system because they have a severe mental illness, they can be included very easily. Focus on social inclusion and on recovery. And one of the advantages of working in a small area is that we can also use the natural resources who are available in these neighborhoods. And we try to describe it that there are three kind of actions a case manager has to involve. Sometimes he's part of the ACT team and then he's somebody's placed on the fact board we will show later. If somebody's destabilization, then he works as one of the team members. The case manager has to focus on what kind of treatments are there, what are available, and about motivation, so which could help you for your recovery, and that's always the focus. The main focus will be recovery. And then we start about Martin, already introduced. When we learned to know Martin, he was 37 years old. He had a diagnosis of schizophrenia, which we learned. What we first hear very soon was he uses a lot of drugs. Everything was available. He had a history with the police. He had been in jail for some time. And he was quite new in our region. And he lived in a shelter in Alkmaar. And he brought some disturbance there. He was dealing drugs also. There were a lot of drugs dealers on the front door because of him. So there was a lot of annoyance, and there was a risk of that he was being pushed out of this shelter. And what he mentioned very clear to the staff working there, that he was not motivated for mental health because he had no good experience with our mental health system. So that was when we started with our FACT involvement.
Yes, thank you. Right. When Michiel is in Alkmaar in the shelter, at first he is visited by the public health mental team. It's a team in Alkmaar where every citizen of Alkmaar can call the team when they are worried about people in their neighborhood. And they are going to visit at first to the situation where Martin is living in, because there are a lot of troubles. And when they think there are psychiatric problems and multi-complex problems, they call our FACT team, because the shelter is in our region. And we make a visit together with the psychiatrist of the FACT team, with the social nurse of our team, and with the public mental health team. One member is visiting him in the shelter. And when the psychiatrist thinks, well, there's a diagnosis of severe mental illness and also, again, the complex problem, then they say, well, this client is belonging to the FACT team. And he's introduced in our team. Oh, that's the wrong one.
The other way around.
Yeah, sorry. Look. And he will be introduced in our team, and that's the moment when we put him on the board. This is our board. It's the symbol of our FACT working. And the next day, after the visit, our psychiatrist introduced him in the team. And on this board are all the people who are getting more care than usual, the ACT care. So 80% of our team clients are getting treatment and care as usual, and when there's a problem, when there's a crisis, or when they're new in the team, they're coming on the board. There's several reasons to... Yeah, I have the good one. There's several indications when we put someone on the board. And I told you about the new client, it's Martin, but there are also temporary reasons. For instance, when there's a crisis coming, or when we think, well, it might become a crisis, then we put someone on the board. Also, when there are life events in the life of the client, maybe moving houses, or it's very stressful, we put him on the board. And when there's a threat of readmission. Also, long-term treatment, we put persons on the board. So I think in the situation of Martin, it will not be a short moment when he's on the board, but he will be long on the board, because there are a lot of big problems. But also the revolving door clients we put on the board. And the difficult to engage people we put on the board. We do that because when our nurses are cycling through the city, they know the names about the people who are hard to engage, and maybe they see them in the street, and they can watch and observe how they look like, and they can tell to the team from, well, I've seen him and it's okay, or we try to make a little contact with them. And that's then the way to have contact with the people who are hard to engage. I'm speaking this, but it's not necessary. Also the people who are in admission in the psychiatry, in the crisis clinic, or in the general hospital because of somatic reasons, or maybe in jail. The people who have legal measurements, and also before and after admission. I will tell you later a bit about it. Well, new in the team, introduced in the FAC team and the FAC board meeting, with the FAC board in the background you see. And yes, we have a FAC board meeting every morning of the week. And all the team members who are working in a day are present at that moment. It takes half an hour to an hour to discuss 30 to 50 clients. And it depends on the team how long it will take. It depends on the amount of clients, but it also depends on the team. Because in my team, we are very hard working and there's less time for social talk. So we do it in an hour. And in that hour, we can laugh, have social talk, and talk about the client. So it's a very important moment for our team. It's a moment when we see each other. The team leader or the coordinator, it's my job. I'm the chairman of the meeting, and it's a very important job because discussing 30 to 50 clients, it's a lot in 1 hour. I have to watch the time, but I also have to try to that all the people can say what they want to say. That it's we are there multidisciplinary, and everybody has his own view on the situation, and it's very important that we talk about it together. So that's better for the quality of our care. Usually we start with some announcement because it's a good moment. We're together. We can tell what other things are important for our team. And the most important thing is make some time to share successes. So when the IPS is in the meeting, well, she tells about a client who has a new job and how he's managing, and we can be proud of what he has become. And well, it makes you a team when you share successes, and it makes you strong. One of the members at that moment at the digital board is making notes on the board. So when you're not working, you can look on the board in the afternoon and see what we decided with each other. There are a lot of goals of this meeting, and the most important goal is the shared responsibility of the team. When the client is put on the board, it's not only the case manager who's responsible, but the whole team becomes responsible. And we also have shared caseload. We are going to visit the client with all different members, maybe, if necessary, every day. And it's also a moment to share information. It's very good for the continuity of care. When I'm working 3 days, so the 4th day I'm not there, and when a family member is calling about his brother or sister and asking something, it's very nice that all the people in the meeting know a little bit about the situation, and you have a better continuity of care also for the family. It's very nice. It's a moment for coordinating the care, because when you are visiting with a lot of members, then you have a good coordination. And I told you a bit before, there's a lot of knowledge and a lot of expertise in this team because of the different disciplines. And we can share a lot of information and a lot of experience. Well, that speaks for itself. This is our board. I thought, well, it might be nice to show you a bit. Here in the beginning, it's the category. We can click on what is the reason why the people are on the board. It's for crisis, it's for admission, etc. The name of the client, when he's put on the board, the diagnosis, and we also can click on the phase of the abuse, of the treatment of abuse. Jurisdictional state, here you see what is the reason for putting someone on the board. And this, I think, the most important part of the FAC board is where we write the goals and wishes of the client. Because I will come later on, because The goals and the wishes are very important in stable moment, but also very important in the moment of... The next, the next part is describing the interventions of the team. And of course, the social network. We're working very close together with the network. It could be the family, but it also could be a housing corporation. I will tell you later. And a visit planner. Who is going which day? We can click on it and make red if it's a telephone call or black if it's a visiting. Well, that's where's the client living at that moment. And here you see which case manager is responsible and which shadow case manager is responsible. Okay, well, back to Martin. What do we do when Martin will be on the board? And our big goal for Martin is how can we get in touch with him? We determine a case manager and a shadow case manager. Also for my holiday, I have a shadow case manager. We try to invite him to the client in the first contact, and so that they know a lot of people of the team. And of course, Michiel is hard to engage. It's not so easy to do that, but when the people are not hard to engage, we try to introduce as much as possible all the members of the team, so they know they can meet them all. For Martin, we try to arrange a daily visit. I think on the board every day there's someone on the board who's trying to visit him, because we think when we go 5 days a week, maybe we see him 1 day a week, and that's so we have to go a lot to get lucky to see him. The shared caseload, so I told you, not only the nursing are trying to meet him, but also maybe the psychologist or the specialist for dual diagnosis is visiting him. And what we do is try to search for a click. I think you do the same. Try to search for a click in the contact with the client so you can talk. And we try to have a first treatment plan in the first period after 6 weeks. And in that period, we also try to find resources of the client. We try to search for relatives and family, and sometimes they are hard to find, but when we find them, we try to arrange a meeting with the relatives. And of course, a meeting with the client if he wants to. I think with Martin it wasn't possible, but also have a meeting with the family without the client. We think it's very important that the family or the relatives or a friend are telling their story about the situation. There has been a lot of pain, there has been a lot of trouble in the contact with Martin, and before they joined the team, a lot happened, and it's very important for family to tell their story, but it's also very important for us to gather information. The family knows the client, and they know exactly what are his ways of living, and how maybe also for cooperating with the family, they know how can we meet him, what are the best ways to talk with him, where can we find him. But also, of course, we want to know, does the family need support? And, yeah, and give some psychoeducation, and we make appointments with each other from what do you like as a family member? Do you like to have close contact with us? Do you like to have more appointments about your own support? Because it's very hard to be a relative at some moments. So we make appointments about that. And in that period, for the first contact with Martin, we also try to get contact and information with the neighbors. I think in the situation of Martin, he was in the shelter, so it was not at that moment that there were a lot of neighbors. But there are people who have neighbors, and also the neighbors have a lot of troubles, and it's very important to get in touch with them. Not talking about the privacy of the client, but explaining about the situation. And most of all, I think it's very good to explain that you're involved in the situation, and when there's trouble, they can call you. And also the housing corporation is also very important to have contacts, because when we're working together, people are not paying their rent maybe, and we can explain to the housing corporation that we're involved, and maybe we can search for some understanding and also make appointments about the roles. For instance, the housing corporation can be the bad man and say, well, if you don't pay your rent, or if you don't do that, then you're going out of the house. And then we can stand next to the client to find ways to keep his house. Well, after 6 weeks, I think it's not really good with Martin.
So give
A little short, yes.
Right. Martin, as you can see, is still hard to engage, causes a lot of nuisance. We try to discuss his daily contact, but he has some problems, and he noticed, of course, the risk of being homeless, and he has financial problems because he still didn't have his insurance arranged. So he has some questions he wants to have where the factoring can be involved. And one of the issues we thought was that the peer specialist could be a good entrance. The peer specialist in this team also had a diagnosis, but also had a substance abuse history. And what we know from the small research from peer specialists, that they are good in engaging those persons really hard to engage. So one of the things we tried was that a peer specialist could play a role in engaging Martin. But that's for sure, Martin will be on the board because he's still hard to engage, which is one of the criteria for the fact board.
Yes. And the fact team is, just as Michiel told, he is searching for the common goals. He has no income, so we try to arrange payments. He has a lot of debts, so we try to agree with creditors. He maybe for his debts there's an administrator necessary, and well, we'll talk about it with him, but in this moment I think he don't want that. But when he feels that he is supported, and he feels that we are next standing to him, there is growing a little bit of trust. Also because we search for housing, maybe a better housing than the shelter. He would like that, I think so. Well, also, I already told you about the neighborhood, the contact we have, and when he feels that we are helping him, then it's better, then it's more easy to getting a bit of trust. And the peer specialist, of course, she is more focusing on strengths and more focusing on empowerment. And at this moment, it's more, I think, as well, that he feels a bit the same. So she is not she is a member of the team, but she has already also had the problems that he has. Well, but when we help him, like I told you, and a bit of trust is growing, then he still be on the board. But the contact is more regularly. The case manager is visiting him weekly, and the psychiatrist, who was really a lot involved because of the problems, is now a bit more on the background and seeing him less. And the DD specialist, I think at this moment he is more involved. He's used, in our team everybody is trained in a double diagnosis treatment, but he's very specialized in it. And he uses motivational interviewing and is also trying to do some scale, using a scale instrument for alcohol and drugs abuse. And when we can talk to Martin, we try to find the goals with him together and also with the relatives. Our basic goals are, of course, medication, less nuisance and less debts, and maybe a bit of motivation for the DD clinic. But he has his own goals, and that's very important that we try to put them also in the yearly treatment plan, because every year at least we make a treatment plan with the client, and there's a meeting with multidisciplinary persons, not all the team is there, but the psychologist and the peer specialist and the psychiatrist and the case manager with the client, and we also invite the relatives at that moment. And before we have such a multidisciplinary meeting for the treatment plan, we also use the screening instruments for in what situation the client is in, but also for, well, I would say the MANSA.
Quality of life.
Yes, a measurement for quality of life. And also at this moment it's very important to make a relapse prevention plan. And of course we try to do it with the client and with the family. So back to Martin, I think.
Yes. Yeah.
Yes.
Well, Martin, we are a year later now. Martin didn't stay in the shelter. He wasn't happy there. The shelter wasn't happy with him. We couldn't find a house for him at that moment for a house company, but there was a place in one of our sheltered living houses, or sheltered housing. Meanwhile, he was admitted once by force and once voluntary, mostly because his using speed, and he gave him a lot of nuisance. Since he's in the sheltered living, he says he's taking medication. We have some doubts about that. He's not really motivated for treatment. He's still using a lot of drugs. And the other two patients living in this house are also using a lot of drugs. And when you visit this house, probably the most of the time you'll see them sitting on the bank, drinking or smoking, and they don't have a lot of day activities. And as Jeannette earlier mentioned, the goals of the team were probably more problem-focused. So they were focused about what can we do about the substance abuse. We tried to motivate them to stop his use of cocaine and speed, at least. We tried to motivate them for activities at daytime. But that wasn't really very helpful. Try this one. Okay. But because in a way the situation is quite stable, he's taken from the board because we know the situation, and he's visited once a week by the case manager, and sometimes the peer specialist is involved.
Yeah,
so that's the reason to get back to the board.
Get back to board. And there we have a procedure for taking someone off the board. We do it when the situation is normalized. Yeah, what's normal, but normalized. And we only make the decision to get someone off the board during the meeting, so everybody is there. And a very important part of taking off is the evaluation of our interventions. And in the situation of Martin, he was on it a long time, but especially evaluation is very important when people are on the board for a short time. By preventing a crisis, so we can learn what did we do, what helped, and what can we do next time, and that's why we adjust the relapse prevention or the crisis plan. And of course, when he's off the board, we still are involved, and still there's a bit of shared caseload, because on the moment that he's not on the board, even then the peer specialist is visiting him. Even then the DD specialist is visiting him. And even then we as a case manager are visiting him, but also staying in touch with the family. We made in the earlier meetings appointments with the family. What will you have? What will be the frequency of the contact? And that's how we are staying on speaking terms. But also we have family groups. We have groups for psychoeducation, or groups for the family to learn about motivational interviewing. And maybe the family of Martin is going to such group. And of course, we make appointments with the family about their support. And I think, well maybe at some family we have a meeting once a month for supporting, but it depends on what they want. And of course we have a regular contact with the living corporations. All the team members in our team focus on different network organizations, and everybody in the team has a meeting once in two months, 3 months with that organization, and bringing the information about how do they work, what are the well, I don't know what to say. How do they work, and we talk about the clients, how are they functioning, and it's coming back into the team. So one is seeing the police, one is seeing the housing corporation, one is having contact with another organization, and all that information comes back to the whole team. Well, after a long period of normal contact with Martin, I think he has a plan.
Well, the peer specialist started to talk about his dreams and what he did do earlier. And what he did earlier, he had a degree in electrical technician. And he said, oh, I'm not interested in activity centers, I'm not interested in volunteer work, I want a job. That's the only thing I really want. I'm not motivated for training. So then the supported employment specialist, who was part of the team, is introduced. And she started to talk with him, okay, what are your ideas about work? And the concept of IPS is, supported employment, is the concept of place and train. So you try to find a job as soon as possible, a competitive job where everybody can solicitate, and you try to place him as soon as possible and then try to train and support him on this spot. First, his idea was to get back as an electrician, and the IPS worker took him to a company where electricians work, and they walked around for a day, and they discussed what he needed to work there, and he came to the conclusion that, well, his degree was outdated, so he had to have a new schooling, and he wasn't really eager to do that. He wasn't eager to go to school. So then the discussion was, what do you like in a kind of job? And to make it short, he said, well, I want to work independent, I want to work outside, and well, to earn my money. And the first option they found together was to work as postman. And it has some voordelen, okay. So now he works 4 days a week. He started to work as 4 days a week. He got paid for 2 hours a day, but they ask him to deliver the mail between 12 and 4, so he can take 4 hours to do it. And in the first weeks, the supported employment specialist went together with Martin, how to do the work, how to draw. She drew a map, how to walk. She learned him how to organize the post, and he was very happy in his job, and he was especially very comfortable with the suit he got, this jacket. He was very proud of this. So the moment he put it on, he was a postman, and he felt like a postman, and he acted like a postman. But then, not quite some weeks after this, first he didn't show up at work. He should have been there on Monday at 12 to get the post. He didn't show up, and the post office called the IPS worker, and he was still asleep, so she went to the home, wake him up, and said, Martin, you have to do your job now, and together they went to do the post. But another week later, things went really wrong. He didn't show up again, or he showed up too late, and when he came there, he took all the posts, and at the first post office he saw, or the first mailbox he saw, he threw in all the posts, and went back to sleep. And of course you can imagine what happened. Well, the neighborhood was quite angry, the person angry, so there was a lot of telephone calls to this post office, to the post mail services. And they called Martin, and they called the IPS worker and said, well, this is really your last chance. If you do this another time, you lose your job. And that was a kind of wake-up call for Martin. Then he realized that his job is very important, but if he still uses all this cocaine and speed and alcohol in the evening, he always has this problem of waking up in the morning. So then he realized that this use of alcohol and drugs is interfering in his job. And he has to do something about this. Try this one.
But before that.
Okay.
You're going a bit quickly.
Yeah.
Okay. But before that, he is on the board again. And I'm not going to tell all about this, but also there, the procedure. One thing I want to tell is that everybody of the team can put someone on the board when a crisis is maybe coming. And As you see, the psychiatrist is also very important at that moment. He has to see the client within 24 hours after putting him on the board to evaluate the medication he's taking. Well, Martin isn't, but there are a lot of people who are taking medication. And he's evaluating the risk. But also important to say is that at the moment when he's on the board, we also inform the family about it. So the family knows when we are making the higher level of care. Well, crisis intervention, again, the team responsible, again, shared caseload. We can visit the people in the evening and in the weekend. In the evening, it's one of the nurses of the FAC teams, and in the weekend, it's our crisis ward who can visit the clients. We have to make a request in advance when we want them to visit the client, but it's very nice that it's going through the continuity of care in the weekend. We also have Telecare. It's phoning with a screen in front, and that's 24 hours, 7 days a week, possible for clients to call, and it's only a click on the screen and they have contact. In the night, it's contact with the crisis ward. And of course, at this situation, the close contact with the neighborhood and the police. Well, Michiel told you about, he is at this moment getting more motivated for the treatment of cocaine and speed and abuse, and he is his choice is to be admitted at the DD clinic. But he said, well, I will go there, but I will really try to work. So I have to go there, and maybe when it's going better, then I can go to work, even when I'm there.
Yeah.
Yeah?
He actually, he followed the morning program. At 12 o'clock, he put on his jacket.
Yeah.
He was the postman. He started to work. He returned at 4. And then the program started again. So during his admission, it was possible to achieve his goal, and it was to keep his job, which was very important to him.
Yeah. Yeah. Well, in fact work, it's very important to have eye for the recovery every moment, every phase where the client is in. And only the role of the case manager or the member of the team is changing. So in period of recovery, we are more coaching and the trainer, and during treatment periods, we focus more on symptoms, and in the destabilization period, we are of course helping and taking a lot of care and doing more for the client. But the recovery and the focus on recovery goals I told you about has to be in every situation. And because of that, it's very important to work transmural with the crisis or with the double diagnosed ward. And how do we work transmural? Well, our crisis ward, our DD ward also, is facilitating to our FAC team. And that means that the FAC team is responsible for the treatment plan. Also the treatment plan of the crisis ward. And very special, it's really new in our situation, is that the one nurse of the ward is joining in the FAC team meeting once in a month. So she sees which people are on the board, which people are maybe getting in crisis, and she can also tell about the people who are in crisis. And when we find out that when someone of the ward is in our team, the contact is growing. I don't know, when you see people, it's easier to get in touch, and it's also now with the one of the wards. Let me see. Oh yeah. And when he's admitted, there's an intake on the ward, and in that intake we also invite the family. So it's an intake on the DD ward. The ward is there, a member of the ward is there, the psychiatrist of our team is there, the case manager is there, one of the family, and Martin himself. And in that meeting we discuss the goals of admission together, And also we talk about the length of stay. Well, we think what will be the length of stay. And also we make follow-up arrangements in the agenda for follow-up meetings. And of course, in that meeting, we also talk about the recovery calls, because he wants to work during admission, so we talk about it. And hey, something's missing, I think. Well, and when we like to continue the contact with the case manager, so every week the case manager is visiting someone who is in the ward. Then we go to Martin again. Yes, he's going home. And at that moment he will be still on the board. The category is changed. He's not further in admission. He is now after admission in the category, and the support will be as before. He gets EPS again for his work because he has to grow in. The case manager is still visiting, and the DD specialist is giving him management and support in his substance abuse. And he's also joining the active treatment group and the Cocaine Anonymous group. And you can be in that treatment group for only in the day, not for you don't have to be admitted for that. Well, we end the situation of Martin, I think. Yeah.
Yes.
Yes.
Oh, you can. What? The situation is more or less stabilized. He has his own apartment now. You can say, if you look at remission, he's in functional remission. He has his home, his own house. He has work. He has social contacts, although he's not very satisfied about that. He's really working on his recovery, so his recovery process is working quite well. But if you look at his symptoms, he's still not in symptomatic remission. He still has a lot of problems with substance abuse, and he still has problems with hearing voices. So that will be the next focus of the treatment, probably. There was a lot of information you got, and we try to show how it works with an affecting to Martin, and I'll try to summarize it as short as possible. This is how we try to describe the principles. Very easy. The first one is more about the vision. This is the principle, like IPS. We try to, if somebody is motivated, we try to get him as soon as possible there and there. It's like supported housing or supported education. Try to get him as soon as possible in a place where he's motivated, and there we try to support him and treat him. And the focus of this is recovery and social inclusion. And to work on social inclusion, we need, and this is what Jeannette taught often, we need to cooperate with the family, but also with the neighbors, with police and everything. So that's very important to have a good collaboration with all the other parties. Working together within a FACT team. A FACT team is not a standalone team. It's really a team of an organization, but it's well the center of the, it is the center for the persons with severe mental illness. And so this is the vision, this is mere, this is how we organize it, and this is how we do it. ACT, we use the fact board, we have a multidisciplinary team, so we use all the evidence-based guidelines we have, and we focus on the recovery and rehabilitation. We talk this one, and we have some discussion, and then is fact a method or is fact more a model? And I think always it's a service delivery model. It helps us to deliver all the evidence-based practice to persons with severe mental illness. It is available for all persons who are in care. And what can we offer? Medication, psychological interventions like CBT or EMDR, family education, as well as supported deployment, IDDT, and recently, we are more focusing on this kind of groups: wellness recovery action plan, recovery groups, pathway to recovery, shared decision making, and we're working on e-health programs that persons themselves can work on a computer, and we are developing a model for recovery. And the goals for the severe mental illness are integrated. It's not only about psychiatric treatment, it's also about social inclusion, work, and about personal recovery. And the way we work is that we integrate it. So in Martin's case, the focus was first this, and later he became motivated for treatment, and then you see it works together. What did we learn over the past year? As Torleif showed, there's not much research about FACT. This is a model which we developed in 2004, and we're still developing it in a way. And it became so popular that before we could do a well-organized, randomized controlled trial, all the regions already had some FACT teams, so that made it difficult. But we know a few things. We see a frequent shift between persons who are on the FACT board and who are off the FACT board. In 3 years' time, 60% of the persons will have been on the FACT board. We have very low dropouts, less than 2%, even less than 1% now. We see that more persons are getting in symptomatic remission. We're known in the community, and we're decreasing the number of beds. But there are two naturalistic studies. This is the same which Torleif mentioned, but then it's described by Bakker a bit earlier. And what he did, he described the period before they introduced FACT and after period of FACT. And they looked at symptomatic remission. And what they learned was that pre-FACT period, the probability of remission was 90%, and after the introduction, it was 31%. And one of the things Torleif mentioned was that it didn't work very well with persons with alcohol problems. That was also because this substance abuse treatment wasn't introduced then in the FACT teams. Oops. Another study we are working on, and we're trying to get it published now, so it's now submitted, is a study we did in our own region. I showed you 3 regions. One of the regions was West Friesland, and we started with 3 FACT teams in 2009. And we, like the Limburg study, we did a follow-up. We did 3 measurements at July till December 2009, 2010, and 2011. We looked at the numbers of admissions and face-to-face contact during this period. And we made clinical assessments performed by the case managers. So the case managers used the HONOS, they used the MANSA, which is for quality of life, and they used the Camberwell assessment of needs and another scale. And we looked at the fidelity of the FACT teams. To give some idea about the population, this is exemplary for most of the FACT teams in our region. 60% has a diagnosis in schizophrenia spectrum, and the rest is more spread. And about 40 or 50% do have a dual disorder problem. More persons are male, and the average age is about 44. Most people are unmarried, live independent. Very few people have an employment, a paid job still now, and a bit more have a voluntary job. I'm not going to go in detail about the results, but what we learned is that the teams could implement FACT within a year, so then it was above the cutoff score. There was a significant improvement in Camberwell assessment of needs. So there were less unmet needs, and the needs that were there, they were reduced. And on the MANSA, the quality of life, the patients were significantly more satisfied. We saw on all the 3 teams there was less admissions, and the length of stay was less shorter. There were less face-to-face contacts, but both started after a year. So in the first year we saw an increase, and then there was a decrease. No treatment dropouts, we saw a lot of compliance, but we didn't see much improvement on the psychosocial functioning, like getting a paid job or employment status. The focus in the first 2 years is more on treatment, you can expect. Of course, there are a lot of restrictions of this study. There's no control, no factors, so there may be other factors which may explain the results. We don't have a good comparison with early situation, but from different sources, the patient, the case manager, the database, we see that there's quite an agreement in the results. And the professionals are very satisfied. That's something we learn also. Less burnout, they do it together, and they feel much more comfortable with the shared knowledge. So, if you like to give a comprehensive idea about FACT, we try to combine the 7 C's, as Ramos called them. We try to combine the cure, medication. We try to combine it with care. It's about crisis intervention. We try to involve the knowledge of the clients, the peer support and the peer specialists. We work in a community. If necessary, we use control. And using the routine outcome monitoring every year with the tracking plan, we have some kind of check what we're doing. Excellent. So, thank you for your attention. You're just in time.